Good evening, everyone. Welcome to everyone on this call or to those who may be watching us on the YouTube channel. Today we're in Providence, Rhode Island. Rhode Island is the smallest US state, that's what I found. And what it lacks in size, it certainly seems to make up in character. As always, I'm very grateful for our DCR team, which is led by Dr. Galandiak. These are our disclaimers. As custom, a fun fact. So according to Google, Providence has the most coffee and donut shops of any American city, with a ratio of one donut shop per 4,000 residents, which is quite dense, I gather. Another interesting fact related to Brown University, particularly the John Hay Library, apparently contains 3 books that are bound in human skin. Moving on, I'd like to introduce Dr. Adam Klipfel. We're indebted to him for supporting these DCR sessions. Dr. Klipfel wears many hats. Firstly, he's on vacation at the moment, so we're particularly grateful that he was able to support this and attend. But when he's not on vacation, he's the program director of colorectal surgery training at Brown University. So I'm going to turn to Dr. Klipfel to sort of talk about his city, his department, his hospital, and maybe support or disprove the 3 books bound in human skin fact.
Well, thank you, Adam Klipfel here, and I appreciate Vlad, you, and Dr. Glandiak and the whole DC&R Journal Club team for inviting us and allowing us to participate. It's really a pleasure and honor. We really enjoyed the Journal Club immensely over the last couple of years, using it many times in our fellowship program over and over again. It's really been great. So yeah, Providence, Rhode Island is a great place. The state of Rhode Island is really a beautiful place to live, particularly in the summer. The other fact that I always think of is it's actually #1 as far as coastline per square mile. So even more than some of the giant states. So there's some little known fun fact as well. I didn't know about the books bound in skin. That's a new one for me. So I'll have to see if we can find out more about that too. But it has a rich medical history. The medical school was actually one of the first 3 to open, and then was open for a number of years and then closed, and then reopened in 1970 or 71. And so we just had our 50th year of sort of second phase of medical training at Brown. And Brown University is as everybody knows, internationally known. But we have a great residency program here, graduates 7 chiefs, and we have 2 fellows with us every year as well. And these are next slide, thank you. This is Rhode Island Hospital campus there. And in the bottom left is the Rhode Island Hospital from 1900. So the Rhode Island Hospital has been around for a long time. And there's the updated medical school right there in the middle. And to the right is Miriam Hospital, where really most of the colorectal surgery happens. And the immunology center is an amazing division there. And that's where there's a lot of HIV patients. And we'll be talking a lot about that tonight as well. So that all fits in well with this topic. And this is our faculty. I'll just go through quickly each one. Dr. Matthew Vries in the upper left there is going to discuss the first paper. And he's associate professor, and he's our director of surgery at Miriam Hospital, and also just completed and spearheaded the national rectal cancer, the NAPRC. So we just got our accreditation for rectal cancer, which we're really proud of and look forward to working with everybody on that. And Kayla Bassett is one of our current fellows. She's going to be presenting the first paper. And she is from University of Connecticut. And after a year with us here, she's going to go back to UConn and be on faculty there. So we're looking forward to working with her this year. And Dr. Siva Dantu is our fellow from last year, who I decided would be a good person to discuss the second paper. And he is going to be on the faculty in Syracuse at the SUNY Downstate. But he was very excited last year. We were talking about doing this journal club, so I felt it was appropriate to bring him back. And our second fellow, Matthew Carr, below that, is going to be discussing the second paper. And he is from the Navy. He's a lieutenant commander in the Navy. He was the ship surgeon on several aircraft carriers in the Mediterranean and in the Gulf. And he's going to be going back to Virginia Beach and be on the faculty there at the Naval Hospital. So we're also looking forward to working with him. Yeah, and Dr. Schechter is going to be our special guest. He's the interim chief of colorectal surgery at Brown here and has really been responsible for expanding the colorectal division and bringing us all together. So it's really a pleasure to work with him and for him. Dr. Leslie Roth is another faculty of ours. She's one who is part of the Women's Medicine Collaborative here and does a lot of the pelvic floor work for our group. And Dr. Catherine Basinger is our newest member. She joined just recently from Georgia, and she's doing great and is part of the robotics program. So myself and Dr. Basinger do the majority of the robotics for the fellowship. And that's everybody. Thank you.
Oh, fantastic. Thank you very much for that. So before we start with the first paper, we have a poll. The poll for today is, do you use high resolution anoscopy, I'm sorry, I've got, for the management of patients with high-grade squamous epithelial lesions? So please tick what you think is the most appropriate answer. And whilst we've got people filling that out, let's move to the next slide, please. Our first paper is called Impact of Definitive Chemoradiation on Quality of Life Changes for Patients with Anal Cancer, Long-Term Results from a Prospective Study. This paper comes to us from the University of Toronto, with Dr. Honzi being the first author. The paper will be presented by Dr. Bassett, and then we will have Dr. Vries share with us his perspective as a moderating faculty member. So thank you very much, and please start when you're ready.
Good evening. My name is Kayla Bassett. I'm one of the current colorectal fellows at Brown University. I'm very excited to have the opportunity to talk about this article tonight. Next slide. This is just a brief overview of everything we'll be talking about. Next slide. For the background for this article, anal squamous cell carcinoma is rare but increasing in incidence. Standard of care is radiation therapy with concurrent chemotherapy, with the goals being tumor control and sphincter preservation. Maintaining quality of life is important because the disease is curable in most patients. However, there is limited quality of life outcomes for survivors of anal cancer, and this study aims to evaluate the long-term quality of life out to 3 years from treatment, with specific evaluation on impact of radiation dose selection on quality of life. For the methods of this study, they used image-guided intensity modulated radiation therapy, or IGIMRT, as the standard of care in patients with anal or perianal invasive squamous cell carcinoma starting in 2007. This was a single institution prospective analysis. Patients with anal cancer undergoing IGIMRT with or without concurrent chemotherapy between 2008 and 2013 were recruited to the study. Exclusion criteria included metastatic disease, previous pelvic radiation, and T1N0 disease amenable to local excision. Evaluation included a digital rectal exam, MRI, and CT of the chest, abdomen, and pelvis. Radiation therapy was delivered using a sequential 2-phase technique, and there was a different radiation dose based on the T stage, N stage, and size of the tumor. Concurrent chemotherapy was 2 cycles of 5-FU and mitomycin. Quality of life was prospectively collected using the European Organization for Research and Treatment of Cancer Quality of Life Questionnaire Core 30 and Quality of Life Questionnaire Colorectal Cancer 29 at 3, 6, and 12 months after radiation, and then annually into the last follow-up. The scores were linearly adjusted, with higher scores indicating better function in the functional scales and worse symptoms for the symptom scales. There was 96 patients that were included in this study with a median follow-up of 56.5 months. Overall, there was 580 of the C30 and 573 of the CR29 questionnaires completed for analysis. And there was a median of 12 questionnaires completed per patient. In the C30 questionnaire, most scales showed a clinically significant decline at the end of treatment, with improvement by 3 months after treatment. There was long-term improvement noted in the categories of role functioning, emotional functioning, appetite loss, pain, social functioning, nausea, vomiting, insomnia, fatigue, and financial problems. And there was long-term worsening in dyspnea. In the CR29 questionnaire, there was worsening in body image, defecation, sore skin, pelvic pain, and impotence at the end of treatment, but an improvement at 3 months. Overall, there was long-term improvement in anxiety, pelvic pain, and overall, there was long-term worsening in body image, bowel embarrassment, fecal incontinence, impotence, and hair loss. The study also looked at the difference in scores between low dose and high dose radiation, and the only difference was worse dyspareunia in lower dose radiation. Patients who had tumor relapse had worse scores in pain, financial problems, dyspareunia, and impotence. And here's just a table showing for the C30 questionnaire where I highlighted here the clinically significant differences in the functional scales and symptom scales. Next slide, please. And this one was the outcomes of the CR29 scale, where again, I highlighted the clinically significant differences in the different functional and symptom scales. Next slide, please. For conclusions, this study demonstrates slow recovery of some tumor and treatment-related problems, suggesting that more emphasis on symptom control and follow-up is required. Most symptoms, however, were temporary and recovered by 3 months. There was ongoing issues, mainly with bowel, anal, and sexual symptoms. Increased awareness may lead to better management of late effects and better care for cancer survivors. A multidisciplinary model of survivorship may improve long-term quality of life. The strengths of the study included a relatively large number of patients for the disease population and a small proportion lost to follow-up. The limitations of the study included single institution, single-arm study design, and lack of dose reconstruction. So the analyses were based on prescribed rather than delivered dose. Thank you for your time.
Thank you very much for that great summary. If we can please get Dr. Vries to make some comments. Thank you.
So first, I'd like to compliment the authors as well as the patients, both of whose work was really integral to this project. I think all of us like quality of life studies. They're truly integral to understanding the sequela of the disease and the sequela of the treatments that we give. Yet the studies are hard to complete, and I think this group really deserves a lot of credit, getting at least 60% of the patients to fill out the questionnaires up to 3 years. I think, it was very, very impressive, and I think it was a very well done study. I think the, authors did a very good job to address a lot of the questions that probably everybody who treats anal cancer has. We use our anecdotal knowledge to kind of explain things to patients, and so this really scientifically helps us have these difficult discussions with patients. And even though most of the treatment is performed by the radiation therapist and oncologist, it's always the surgeon who has to quarterback the care and follow these patients both from a recurrence and a functional problems that they have throughout their life. Although there were only 96 patients in the study, when you think about, how rare of a cancer this is at one institution, I think that was, a fair number of patients. And I like the way that they use both the quality of life questionnaire 30 and 29. I think they complemented each other well in regards to this. I thought one of the problems with the study, again, was that there were more men in the study than women. And that's kind of opposite of what we see in the United States as far as the incidence of disease. So in 2022, there was around 9,700 new cases of squamous cell carcinoma of the anus. And it was a 2-to-1 ratio women to men in the United States. So a little unusual in their study that there were that the ratio was not similar. I think the study really did a good job of identifying two main things. I think, as Kayla pointed out, it demonstrated, all the functional questions that I think are important, and I think they did a very good job in regards to that. I think the second thing that has never really been reported before is looking at the high dose of radiation. So more than 50% of their patients received greater than 54 gray as far as their treatment planning. And in some of them up to 63 gray, which is very high. And I think this study demonstrated that there was no increase in the scores based on the dosages. And I think it should give our radiation oncologist colleagues some comfort when deciding whether to use higher doses in these bulky tumors and tumors with the higher stages. So I think that was really important. I don't think that's ever been presented before in any papers. I think the last thing that I want to point out is that the first initial questionnaire was when patients have been diagnosed with their disease. And everything else is compared to that. It is not compared to the norm. And, you know, I think some of these patients, when they present, have incredibly symptomatic disease. So all the subsequent questionnaires over that 3-year period are compared to their quality of life indicators at that time, at that moment in time, and not what they were 6 months or a year previously before they were diagnosed with this anxiety-provoking disease associated with a lot of pain, discomfort, and functional issues. So I think we need to pause when we look at this to kind of give us some expectations on where patients are going to be 2 and 3 years down the road after treatment. And thanks for the opportunity to make some comments.
Thank you. That's a lot of food for thought there. I'm going to start with a couple of questions, and people in the audience, please feel free to contribute and send things via the chat. My first question to the panel, I guess looking at the graphs, what jumped out to me is that there was a significant dip in sort of symptoms in the first 3 months in most factors, and then things started to improve. Now, I take your point about sort of the colorectal surgeon being the quarterback and managing this, although we're not giving the radiation. When you have a patient that asks you about potential pain or concerns with bowel functions during the radiation phase, what do you recommend? Do you have a particular regimen? What are your suggestions?
Yeah, I mean, I think that similar to a lot of things, I think we are, you know, very high on fiber supplementation for almost every colorectal disease, and we certainly start with things like psyllium fiber in most patients. In general, patients, as radiation moves on and as the cumulative dose increases, certainly Imodium, Lamodal, medications like that are typically needed to help control you know, a significant number of patients with the disease. As far as the skin issues that occur, you know, as time goes on, I think those can be very challenging. But, you know, certainly patients toward the last, you know, week or 2 of treatment start to really suffer from pain, irritation to the skin area. And we use the typical things like calmoseptine ointment and sitz baths and things along those lines to help you know, manage their complaints. But it's very challenging. I think it's very individualized with patients. So I don't think there's a one size fits all for this disease during the treatment period.
Thank you. The other thing that I took to heart was that it's a very anxiety-provoking diagnosis. Sometimes when I see these patients with anal SCC, they kind of also seem to develop pelvic outlet dysfunction. And I really don't know what came first. Is it the chicken or the egg? Is it the dysfunction that precipitates their pain, and maybe it's associated with the higher risk behaviors, or is it that the radiation precipitates anal spasm and dysfunction? So if a patient presents with an anal SCC and obstructive defecation or levator ani spasm, do you factor that in? Are you more likely to offer a diverting stoma Is there an algorithm we should consider?
Yeah, so I personally think I feel that squamous cell carcinoma in general is a very rapidly progressive symptomatic disease, unlike colorectal cancer. And I think if you go back and ask patients what their functional status was 6 months, a year prior to this diagnosis, I think you get a better understanding of their long-term, functional bowel issues. And I think everything closer in time to the diagnosis is probably more related to the malignant process. We almost never do diverting stomas unless patients are obstructed and the radiation oncologists don't think that they can get the patients through therapy, or with T4 lesions and anal vaginal fistulas and things like that. We certainly would divert patients preemptively prior to treatment. But I think we really minimize stomas, and I think the patients do well because I think they quickly respond to the radiation therapy, and a lot of their symptoms quickly respond. So yeah, so we're very lucky that we're able to avoid the number of stomas that you kind of see in other papers.
Thank you. My next question, I guess, is what do you do if you have a patient that develops an anal fissure during the therapy? Any recommendations of management of that?
Yeah, I think it's pretty similar to somebody with another anal fissure. I mean, you want to try treating conservatively, and certainly sitz baths and fiber and topical creams. But the hope is that they'll recover from that as they recover from the radiation. But you basically, the last thing you want to do is cut anybody's sphincter muscle, I think, in those situations. So try his best to not do anything surgically.
Yeah, fair enough. Botox, do you think that's worth doing, or sort of injecting steroid into the fissure, or is that best not to touch it at all?
Botox, I'm not a big user of it. Some of my partners, I think, are use it a little bit more than I do. I mean, the studies show that the creams work about as well as the Botox for my reading of it, but it's certainly something that I offer to patients often prior to any kind of sphincterotomy. So it certainly could be useful in some of these situations, refractory patients. I've never done any injection of steroids. I think just the tincture of time and healing is probably the best.
Can I ask a question? Are you talking about
if any of my partners
fissures?
have any other thoughts about Botox or other ways to treat
Yeah, I mean, I think you have to be careful
Sorry,
with
couldn't hear that.
the language. A fissure is something typically that comes from hypertonicity of the anal canal, and sometimes we use the word fissure for other tears in the anal area that are related to other disease processes. And I think you have to try to balance those out, that the tears and the pain in the anal area from the treatment response, I think the etiology is different than what we typically see with a true anal fissure. And so I think you have to be careful in the way you treat it.
Can I jump in here for a second?
Absolutely, Dr. Goldstein.
So I agree with Matthew 100%. These are not fissures. They are horrible, horrible sloughing from the chemo radiation where they have high-grade dysplasia. And I think some of the worst tolerability you're going to see are not the ladies who have a single cancer and that's it. When you see people living with HIV, with anal cancer, they almost always have extensive HSIL. And they're the ones that are going to be the hardest to get through radiation and the most morbidity late, because basically the skin just sloughs wherever there's HSIL. So no sphincterotomy, you just got to get them through the radiation. with topicals.
Thank you for that. That's very helpful. Now, I've got a slightly different question, and I'm grateful that Dr. Riccardi is also on the call. We have featured one of the other papers on Twitter, or X as it's now known, this month. And the paper that we featured was "What is the risk of anal carcinoma in patients with anal intraepithelial neoplasia 3?" And we may talk about that in the next article. But my question to Dr. Riccardi is, in patients with advanced cancers who've had radiation, when do you decide that it hasn't done enough? How do you sort of get back into the surgical side of things and consider resection, or when do you consider that?
That's a great question. Thank you for asking me to talk about this. I think Grace is on the line too, and she wrote a couple paper with us. She wrote a paper a couple of years ago with us, looking at the timing for surgery. As you know, the recommendations are to wait 6 months, but we saw very high risk of positive margins when patients were ultimately scheduled or destined to have surgery. If the surgery was done beyond a certain time frame, if I recall, it was 3 months. Grace, maybe you can help me out. But you know, even though it was a small percentage of patients, when we got to about 3 months, what we saw was a very high risk of positive margins. So, you know, what that told us is those high risk patients who have big bulky tumors that you know, you're waiting to allow them to regress, that you should really keep an eye on them and see them back in clinic often. And if you don't see significant regression of the tumor over 6 to 8 weeks, that those are patients who probably need to go to the OR. Grace.
Yeah. Yeah, no, so Dr. Riccardi and I wrote the paper that he mentioned. So basically the risk factors that we saw, so in people who were most likely to have positive margins, if you waited longer than 3 months, it was people whose tumors were greater than 5 centimeters at the time of diagnosis. Men were also more likely to have positive margins, and then if they were poorly differentiated. So what our paper found is that, you know, the Act 2 trial shows that the radiation continues to work for 6 months later. So a lot of times we're getting more aggressive at, you know, waiting 6 months before taking biopsies, restaging, and considering an APR. But, you know, I think we all know, you know, the tumors that are huge, like the 5 centimeter tumors, poorly differentiated, you know, those signs may push us to consider just doing a salvage APR sooner. So the threshold that we used was 3 months. But I mean, there was a very high rate of positive margins. It was about 19% in that paper.
Thank you. That's very interesting. I'm sort of sharing a patient with a similar sort of scenario now, and we're not sure whether we should take them to surgery earlier. I guess this is a perfect segue to start talking about sort of observation and monitoring the anal canal. So let's move to the next paper, please. So paper number 2 is a prospective dual-center trial of circumferential radiofrequency ablation of anal high-grade squamous intraepithelial lesions demonstrate improved long-term efficacy over historical controls of targeted ablation. This paper is from Mount Sinai in New York, and Dr. Stephen Goldstone is the first author and has been kindly made himself available and is on the call. Now the paper will be presented by Dr. Matt Carr, and then Dr. Dantu will voice his opinion as moderating faculty. Thank you, and please start when you're ready.
All right, excellent. Thank you for this opportunity. My name is Matthew Carr. I'll be presenting a prospective dual-center trial of circumferential radiofrequency ablation of anal high-grade squamous intraepithelial lesions, demonstrating improved long-term efficacy over historical controls of targeted ablation. We go to the next slide, please. This is just a quick overview of what will be covered using circumferential RFA. HRA is performed at 3, 6, 9, and 12 months, and then the risk of recurrence was less than historical controls. All right, next slide. So current therapy of targeted ablation of high-grade squamous intraepithelial lesions, or HSIL, is associated with high rates of recurrence greater than 50% in 1 year. Many of these recurrent lesions are seen in areas not incorporated in the targeted treatment areas. The authors sought to limit these recurrences by utilizing RFA, which is already used in Barrett's esophagus, and apply this technique to a new patient population. Next slide, please. So men and women between the ages of 18 and 75 years of age with previously documented HSIL on high-resolution anoscopy entirely within the anal canal were enrolled, though 95% were male. People living with HIV were enrolled if they had a viral load less than 50, CD4 count above 250, and taking antiretroviral therapy for a minimum of 3 months prior to enrollment. Exclusion criteria included anal canal condyloma of greater than 0.5 centimeters, coagulopathy, anal canal stricture, incontinence, symptomatic scarring, history of anal cancer, immunosuppressive therapy, or HSIL treated within the past 3 months. For the procedure, they underwent high-resolution anoscopy, biopsies of HSIL, areas of previous HSIL, and biopsies of unaffected tissue, followed by circumferential RFA with a Barks anorectal wand attached to the Barks Flex RFA energy generator. Participants returned at 3, 6, and 9 months for HRA. Adverse events were recorded. Any lesions suspected of HSIL were biopsied. If it was identified, the participant underwent HRA-guided targeted RFA. At 12 months, participants returned for their final study visit with HRA and biopsies of lesions suspicious for HSIL. Sites of previous HSIL, if no lesion was seen, a random sample was then taken from their approximate site, and random biopsies of quadrants not requiring biopsy for the above-mentioned reasons. HSIL at the 12-month endpoint could have the lesion treated with electrocautery targeted ablation. Participants could then enter off-study follow-up care consisting of an HRA at 6 and 12 months as appropriate. Next slide, please. The 12-month recurrence for the sample rate was 39%, which when evaluated against historical controls is lower than the 49% recurrence in HIV-negative patients and 53% in HIV-positive patients undergoing targeted rather than circumferential RFA. At 24 months, this trend continued with 41% recurrence versus 57% and 68%. An early plateau is noted, as we can see on the right, with individuals experiencing recurrences prior to the 9-month mark in the trial and few occurring after this point. Adverse events were evaluated at each follow-up, with pain and bleeding noted to be the most common at 85% and 91%. Each of these was reported as mild by the majority of patients experiencing them. And next slide, please. So overall conclusions of this paper, the 12-month recurrence after circumferential RFA was 39%, which is often superior to historical trials of targeted ablation. Early plateaus of recurrence were noted, with a plateau noted at 9 months as opposed to 2 to 4 years seen with targeted ablation. Final words, overall, decreased long-term recurrence over previously reported trials, but with increased post-procedural pain as well as bleeding.
Thank you very much for that succinct summary. That's great. Dr. Dantu, can we please have some of your comments? Thank you.
Yeah, so first, I just would like to thank Dr. Cookfell and the community for allowing me to speak. I would like to congratulate the authors on the development of this technique. It was a really well thought out idea with good analysis, great follow-up and surveillance, and great outcomes. And as we know, this is a very difficult to treat patient population. And the authors are known as the experts in the field, one of which is actually on the call. So the first thing I thought about when I read this paper is we've all had these patients with this HSIL that's over 50% of the circumference of the anal canal, or this multifocal HSIL, and you think to yourself, how am I going to clear this patient, or what realistically are the chances of recurrence? And this seems to be a great option. So as Dr. Carr was saying, that the recurrence rate was about 40% in this study. If you look at historical controls, particularly from the paper that Dr. Goldstone published previously, it was about 60%. And what was unique to this therapy was that the recurrence plateaued earlier than what you expect from a targeted HRA and ablation. So there were early recurrences, but once you hit past the 1 and 2 year mark, the chance of recurring is very low. Whereas when you looked at targeted HRA, it could be up to 60%. I do think, another thought is that this is a very attractive option, particularly in people who are part of a very busy colorectal practice. HRA can be very time intensive, and with the high recurrence rates, it could be quite laborious, especially if you don't have a APP to share the burden of it. And there's a learning curve to it, so that's a point to make. The outcomes were quite good overall as far as adverse outcomes. There's bleeding that's expected, and the pain lasted for about 21 days, but the majority of patients either had mild or moderate pain. So I guess I would liken it to perhaps a THG procedure. So it's something to think about, is balancing the morbidity of this procedure to the frustration both the provider and the patient could have about recurrence and having to come back for repeat ablations. Something else, thinking about circumferential ablation in the anal canal, you get worried about incontinence and stricture. And so if you look at patients who've had Barrett's esophagitis and ablation for that, the stricture rate goes between 1% up to 12%. But the authors here did not notice any stricture rate, which is really helpful. You would expect some degree of incontinence because of the sampling that occurs down in the anal canal, but they actually didn't notice that. Now, a couple of things. There was a lower sample size than anticipated, and so you would have to take some of the complications, particularly incontinence and stricture rate, a little bit of grain of salt as it's subject to type 2 error. And the other thing is generalizability. The vast majority of the patients in this population were male, 95%, who were relatively young in the mid-40s. And the exclusion criteria excluded patients with incontinence or even symptomatic scarring, which we've all seen those types of patients too. The follow-up, the median follow-up was about 1.5 years, although they had a few patients that went up to 6 years. So ultimately, potentially having a larger cohort with a higher median follow-up with the wide exclusion criteria and perhaps including patient outcomes might be helpful. Something I thought, I was curious about from the paper as I read it was actually when they surveilled, and maybe Dr. Goldstein could talk about this, but when they surveilled these patients 3, 6, and 9 months, how did it look and how would they identify HSIL in these patients? What kind of scar or post-treatment effects did they find that were unique to this technique?
Thank you very much for those comments. Yes, Dr. Goldstone, who is the primary author of this paper, that's, I think, a perfect segue for him to give us his opinion, and that answer would be great.
So I would not have expected any incontinence per se. We called any kind of discharge incontinence. That's what the sponsor wanted. It's very superficial. We're not going deep. The sphincters are well below any area that's being treated. And, at 3 months, sometimes you could see a little superficial ulceration in a couple of places, but by and large, they were really well healed. And I think we go much deeper with the cautery than we do with the RFA. We're giving 3 pulses, and we go around the anal canal. We're not debriding. We're just touching it and giving 3 consecutive pulses. I think the beauty of the treatment is that we're getting disease HSIL that we might not have been able to pick up with HRA. I think it's a much more expensive proposition than electrocautery. We did it under MAC, but I think that the way I would see it being used, not for someone with a single H cell, but someone with extensive H cell, or multiple scattered areas, and then do the touch-ups afterwards with an electrocautery.
Thank you. One of the points from the chat mentioned sort of challenges of HSIL in the presence of immunosuppression of whatever cause. Does your management change in patients who are immunosuppressed either due to HIV or organ transplant or something else, or is the algorithm the same irrespective of that?
The algorithm is the same. The problem is that the more immunosuppressed someone is, the greater the likelihood we saw of more extensive H cell. And what we showed originally and in this paper and in multiple other papers is that the more H cell they have, the more likely they are to recur. And Anchor showed us the more H cell they have, the more likely they are to progress to cancer.
I see. Next question. One of the other articles we had this month was a pilot study on the immunologic, virologic, and pathologic consequence of intraanal 5% imiquimod for high-grade squamous intraepithelial lesions. And in that article, they report 35% of patients had a reversal from high-grade to low-grade AIN. I guess it's a slightly older study, following 9 weeks of topical therapy. So how does that relate to RFA in your opinion, or other ways of ablating the lesions?
I basically think imiquimod is akin to holy water in people living with HIV. I've never been impressed with it. We're doing a study now comparing 5-fluorouracil with imiquimod in patients. I think the big problem that we've all seen with imiquimod is the high recurrence rate once the treatment ceases. So that's my opinion of imiquimod. I think ultimately the treatment of HSIL is going to be some form of immune-based therapy because we're trying to cure an infectious disease, HPV, with surgery. And I think that ultimately there's going to be some sort of immune modulating therapy that's going to come out, which will be effective. We're trying now new treatment, vaccine, etc. So somewhere down the line, we're going to come up with a better treatment.
Thank you. A shameless plug for the DCR Journal. Dr. Goldstone wrote an editorial about this in January 2022 in that edition. So if anyone wants to read that's quite an interesting article about anchor trial results. Now, my last question I have is actually for Grace Lee. From what I understand, you're very well versed in terms of database research. And in the presence of AIN and the evolution of the terminology from AIN3, say, in the article that you guys wrote, to HSIL, how do you convert the sort of terminology whilst maintaining a larger data set? If you're doing a retrospective study over the last 10 to 15 years?
Yeah, I mean, I think it's a good question. It basically depends on what data set you're using and how these things are captured. I think a lot of data sets don't have precancer. A lot of cancer databases don't have a lot of precancerous lesions. So I think we were lucky because for our paper, we used SEER, which did have cases of AIN as well as anal cancer. So we were able to sort of follow patients longitudinally and see how many people who had AIN3 subsequently developed anal cancers. You know, in that database, we only could see the patients with AIN3 and they were still using that older terminology. So, you know, that's one of the limitations of that paper where we could only look at people with AIN3 and not necessarily HSIL or AIN, you know, AIN2 or HSIL under an umbrella term. So I think you basically just need to see how these lesions are defined. And if it's an older data set that uses AIN2 and AIN3, then you can include those. You know, I'd imagine that there's a lot of data sets that probably have just mixed groups. So you would basically need to go through and pull out patients with HSIL, AIN2, and AIN3 in order to identify them. But there aren't that many cancer data sets that have these precancerous lesions.
Thank you.
I think also, you know, the use of P16, a proliferative marker, is really, a lot of AIN2 was probably AIN1 before we started using P16. And I think that, so I think that we're gonna, going forward, have much better characterization of what is HSIL.
That's interesting. Now, on that, at that point, I think let's move to the results of the poll, because that's, I think that flows quite nicely. Stephen, would you mind summarizing, please? Thank you.
Yeah, so we have on the poll a preponderance of people who do provide the service of high-resolution anoscopy. Not too surprising, since we are selecting, you know, our nice HRA-friendly group. There's a 12% that wanted to pick a fight and are skeptical of the benefit of HRA, and then a number of people that fall in the middle don't have equipment or refer generally.
Thank you. I have a question to the panel based on this, and I guess, granted, you have a far greater experience in this particular field, but what is your institutional algorithm in monitoring patients with HSIL, and what would you recommend for others to follow?
I think for me, certainly if I find somebody, we do pap smears often for these patients, and that's how we can identify them. But I will refer on to Steve Schechter in our group to do the HRA. He's the one who handles that, and then he'll continue on and follow those patients generally. So he could answer if there's and I think that's going to be part of his presentation, is about what the algorithm is for us.
Thank you. And I guess one more comment on that. In patients who have hemorrhoids or significant skin tags, would you be comfortable surveying that, or do you think it needs the sort of region needs to be simplified and some of those skin tags, which may appear benign, excised?
Steve, you want to answer that?
Sure. By the way, Vlad, thank you very much for inviting me. That's very kind of you. Dr. Steve Goldstone is Dr. Steve Goldstone is such a giant. I'm dwarfed by him, and I appreciate that he was on the line. That's excellent. You mentioned something about hemorrhoids. Hemorrhoids definitely make a HRA very difficult. There's no doubt about it. They bleed more. They prolapse. I did a patient I was going to do just anal condyloma on them, and they, you know, during surgery, the hemorrhoids popped out. They were huge, and I spoke to his significant other and allowed me. I said, I'm going to do a hemorrhoidectomy. We'll finish up the condyloma, you know, down the road. And the partner said, fine. Of course, the patient hated me for about a year. Now, he had to come back to me because no one else does high resolution anoscopy in Rhode Island. So anyway, he did fine. But hemorrhoids make things a little bit more difficult.
You know, I want to say something about the tags. We found very high rates of HSIL in these tags in patients who have HSIL, you know, that you may not be picking it up. The other thing is, we also have had some submucosal cancers now in people who've had hemorrhoidectomies and rubber banding. I had one myself with rubber banding. Other people have had with hemorrhoidectomies. I think you have to be very careful with these patients with active HSIL. You know, you're walking between a rock and a hard place, between being able to do a good HRA and burying the HSIL under the mucosa. And that's a phenomenon that's described in the cervix as well, you know, so particularly with cryotherapy. So it's a problem.
Yeah, Steve, I think that sometimes it's the CISCA, which is sometimes you get this microinvasion from scars of areas that have been left. But yeah, absolutely.
Well, thank you very much for that. Now, let's move on to the special guest segment, which we've kind of inadvertently started. So the special guest is Dr. Steven Schechter. So he is the clinical professor of surgery at Brown University. Clearly his research interests are related to anal cancer and papilloma. He's also the chief of colorectal surgery at Lifespan, and has sort of other special expertise within the colorectal disciplines. So I'm very grateful for him to attend, particularly given that he's just finished operating. So if Stephen, if you can start your lecture and we'll give the slides up, that would be fantastic. Thank you.
Oh, sure. Thank you. I was doing tonight, I was doing what any good colorectal surgeon does at night, take care of diverticulitis in the operating room. Anyway, so this slide really shows the problem. You know, if you look at estimated cases in 2022, it's over 9,000. For 2023, it's certainly over 10,000. In 2000, it was only 3,000. The year 2000 was only 3,000 in the United States. So it's certainly a difficult situation. And I think Vlad was a genius in picking these two journal articles, because think of it, one article was on early intervention with radio frequency ablation, how to take care of it. The other article is at the other end of the spectrum. What happens when you have anal cancer and you need treatment, and there are major league complications and problems. So it really shows the spectrum. I thought that was nice. Next slide. This is Dr. Goldstone is great when he shows this slide. And this basically, it's complicated. But if you just look on the left side where it says MSM, and you look at anal cancer incidence. If you look at the yellow circles, that's HIV. If you go, it's HIV negative, but if you, it's low incidence. But if you go up, look up to HIV positive, the red circles, you'll see in different age groups, the incidence of anal cancer goes up. So MSM is a very hot spot for HPV, of course, and getting anal cancer. But HIV is certainly much more deadly. If we look at other, like all the way down to the right, immunosuppressed, sure, women with gynecological CIN, a neoplasia, they're all at risk. But if you notice for each of the groups, if they're HIV positive, it's a higher incidence. The next slide. So basically, you know, you have patients that are going to be sent to you who they may have had a colonoscopy, a hemorrhoidectomy, or something showing a high-grade squamous intraepithelial neoplasia, or AIN. So we use the word HSIL, as you know. So if you have a patient with let's say essentially with HIV or MSM in that group, you're going to do an anal pap smear. Now, anal pap smears are very important to know how to do correctly, and that's going to be saving lives. So if you do an anal pap smear, it can come back normal. That means you're going to repeat it because in a year for people with HIV, or 2 to 3 years in people without HIV, but in groups like men who have sex with men. If it's all the way to the right where it's LSIL or HSIL, you're going to do a high resolution anoscopy because you're looking for those cells. You may have an area in the anal canal with that disease process. If you're looking at the center one, it says ASCUS, ASCUS. Now, this is from Mount Sinai, New York City. We never knew what to do with these groups. Do we do a high resolution anoscopy on them or not? But they looked at looking for high risk HPV DNA for 16 and 18, the viral strains. And if it's positive, then you do a high resolution anoscopy. If not, you repeat it the following year. If they're positive for AIN, one, or if they're positive for LSIL or HSIL, we do a high resolution anoscopy. First, because HSIL you want to destroy, seek and destroy, but LSIL is usually a marker for HSIL, and you want to make sure that they don't have HSIL. So that's all. That's an anal pap smear, all in one nutshell. Either it's normal, atypical, low grade, or high grade. Any questions on that before I move on?
No, I think that's great. Thank you.
Oh, good. Next. Okay, if Dr. Goldstone is in the crowd, he's still in the crowd, he may want to comment as well. When you do a high resolution anoscopy, and I do that in the operating room, Dr. Goldstone does it in his office. He has an amazing setup on West 23rd Street. And more than 50% of the people who do high resolution anoscopy are done in the office, some of them by nurse practitioners. So, but I found being in the operating room, they don't move around much. You sometimes are treating other lesions like condyloma. You may want to have suction around to evacuate the smoke. But this is what you would see. In the center is the pink tissue, that's rectal. And we're looking at the transition zone, which is between the dentate line and the rectal mucosa. It's about 1 to 2 centimeters. And you get whitened plaque. And here you see some whitened plaque. It's called a mosaic pattern. It's kind of, we're talking about angiogenesis. Just thickened plaque could be low grade. But once you have angiogenesis, that means this is moving on to something that is precancerous. And so that's one pattern. There's another slide that will, the next slide will show, again, thickened white plaque. Below, you'll see the mucosa, the rectal mucosa. But a thickened white plaque has some punctate lesions in it. Little red dots, and that's another sign of high-grade disease. Next is classic, and this is, if I'm going to see HSIL, it's going to look like this. And, we biopsy it with a tisular biopsy probe, very tiny, like a 6 by 8 millimeter biopsy, 6 by 4 millimeter biopsy, and we'll send it off. Then we'll bring them back to do ablation of this. This is a little extensive, and this is what Dr. Goldstone was talking about. When you have a lot of this, a lot of HSIL, you may want to use the ablation technique, which would be more appropriate for this. The RFA technique, of course, that instrument is quite expensive, and if you're not sharing it with GI with Barrett's esophagitis, it may be a very formidable price to pay. Anyway, so this is a classic HSIL. Next slide. The anchor study came out.
Can I just interrupt?
Basically, simply, Dr. Goldstone presented this at the ACRS meeting in Seattle. And 4,000 plus patients were randomized to either either being followed with high resolution anoscopy or just being followed in the office. And bottom line was people who were followed with high resolution anoscopy had less progression, less anal cancer than those who were just followed in the office. Bottom line has been, for the last 10 years, there have been arguments at the ASCRS meetings, other meetings, about why do a high resolution anoscopy, just check them in the office. And this puts the nail in the coffin, without a doubt. And Dr. Pilevsky was the principal investigator. Next. That may be the last slide, I think. Oh, this is just the New England Journal of Medicine article that Pilevsky and Jay and Goldstone wrote. And again, this is the key slide in that article, that in the treatment group, the people who had HIV, who were over the age of 35, and who didn't have any vaccinations for Gardasil or anything like that, when they underwent treatment, there were only 50 or 6% lower rate of getting cancer. And the active monitoring group had a higher rate of anal cancer. Notice the numbers, 9, 21. They're small. That was the problem. People who believed in destroying HSIL to avoid anal cancer always had this problem, because to prove that you had less anal cancer, you need thousands of patients. And that's why the Anchor trial was very successful. I think that's it. And that's one of my teachers, Ted Eisenstadt. Very important information.
Thank you very much for that. I've just got 3 questions to round off today's session. And I'm very grateful to all the presenters and participants. My first question is, when you were showing pictures of anoscopy, and you talked about sort of the mosaic pattern or some sort of vascularity of the region, how is that different to seeing telangiectasia after radiation, for example? Because we sometimes can see scar or even sort of small blood vessels forming. Do you, in patients who've had radiation, either for anal cancer or for something else, can you get confused for HSIL, or is it different?
You know, great question, Vlad. It's different. The blood vessels in radiation proctitis are very erratic. They don't form a normal pattern, and they're larger. You can see with the naked eye. Where angiogenesis, you're going to need a microscope, a colposcope.
Thank you. The next question I have is, I guess, the role of the HPV vaccine in patients who already have anal intraepithelial neoplasia. Do you recommend it? If so, when do they get it? When do they get benefit from it?
Well, let me just tell you that in the early 2000s, I had my 2 boys vaccinated, and the pediatrician said, it's only for women. And I said, I don't think so. He says, it's going to cost you $500 a pop. I said, it's worth it. Well, you know, it's for a lot of people. HPV is highly prevalent, big problem. You know, it's recommended for kids really starting at 9, but mainly 11, 12, 13. And it's 3 series of shots of the vaccines. But it's been extended. I usually it ended at 26, but it's been extended to 45. And the reason, Vlad, of that is that people still have intercourse sex with other people. They may have other relationships, and they may pick up other strains that are oncogenic, and therefore are still at risk. So it is it gives protection. And more than that, you know, Pilevsky and Goldstone over 10 years ago looked at about 300 patients who of HIV. They looked at those vaccinated and those that weren't vaccinated, and the ones that were vaccinated had less HSIL than the others. So by preventing the oncogenic strains of HPV, they also showed, you know, you also have a decreased amount of HSIL, which is very important as a benefit.
Can I jump in here for a minute?
Yes.
It's Goldstone. So I published a paper on the 10-year follow-up looking at the HPV vaccine. And the interesting thing, and in all fairness, I was an investigator on the trial as a disclosure. So the deal is this: when we initially did the trial, half got vaccine, half got placebo. When we vaccinated the placebo participants at the end of the initial trial, we continued following everyone for 10 years. And what we found was, after a period of about 2.5 years, there was a washout of disease. In other words, someone who already had HPV 16 could come up with HSIL for about 2.5 years. After that, there was almost no disease. The Kaplan-Meier curve flattened. So there clearly is some benefit to what we call vaccinating people who have disease. Not that it's going to cure the disease, but it's probably going to prevent either reinfection or reactivation after the initial washout occurs. So in my practice, certainly anyone up to age 46 is probably going to get the vaccine covered by their insurance in the US. But I would say vaccinate anyone with HPV-related disease.
Thank you. That's very useful. I'm going to take that on board. Now, my last question is about sort of the surveillance of AIN is quite a complex field. So what do you think is the role of the general or community-based colorectal surgeon in this? Because it seems like there's many moving parts. If you only have a few patients, what do you do? What would you recommend?
You know, at the ASCRS meeting in Seattle, Dr. Goldstone was, and please chime in, Steve, your comments are excellent, said that the average colorectal surgeon probably shouldn't be doing high resolution anoscopy. I think it's awful for colorectal surgeons to lose any ground. And I do say it's important to do it. The question is, I'm getting overrun with these patients, and you do have to be dedicated to it and have time for it. It's something that if Dr. Goldstone says flat out, if you're not going to do 20 to 30 cases a month, listen, you probably shouldn't be doing it. I do about 20.
I said 10.
What was that, Dr. Goldstone?
10.
10. Okay. He's saying 10 a month. Okay. So if you want to do 10 a month, then that's great. By the way, it's important to take a course, and the International Anal Neoplasia Society, IANS, has a wonderful course that's offered online. People should definitely think about that. You really have to follow it up, because if you do it here and there, you're going to be missing patients, first of all, you won't be able to identify some of these HSIL lesions that are kind of odd. It's a skill that you have to develop and stay with. There's no doubt about it. So you really have to dedicate yourself to them. Look, people have to dedicate themselves to rectal cancer. Good question.
I think most colon rectal, like Stephen, is getting overrun with it. I think that this is where an advanced practice clinician can really help the colon rectal surgeon. Like a nurse practitioner, a physician's assistant can do the HRA splendidly. And the more advanced stuff you'll take to the OR. And even if you're not that skilled in HRA or don't want to do HRA, you'll see the big stuff. You'll get rid of it. And the dangerous stuff, remember, we're doing this to prevent cancer. Okay, so you'll see the big stuff. And then after you've treated the big stuff, the advanced practice clinician can then go back in the office and touch up anything you may have not seen.
Thank you very much. I think I'm very fortunate that I had all my questions answered. Hopefully the audience would agree. Now, I think this brings this to the end. This is the first session we had in the 3 or so years that we've been doing this on AAN, and I think it's usually an underappreciated topic. At least that's what I think within colorectal sort of teaching. So I'm very grateful for everyone to have dedicated their time, and I certainly think it was very useful, and at least it's very useful for me. So our next session will be in the end of next month, and we're going to the Mayo Clinic, where we will be talking about retrorectal tumors. So I look forward to seeing people there. Thank you again.
Thank you, Vlad. Appreciate it. Thanks for the time.